Well, good afternoon, everyone. It's my pleasure this afternoon to introduce our Grand Round speaker. I have dubbed her the world's wastewater Wonder Woman. I know that's a bit of an alliteration, but if you'll forgive that, it tells you exactly what she's been able to do and to do some very creative things. Her talk today is wastewater and environmental surveillance in Africa, in Malawi. And this she has come to us uh, from Western Washington University, where she was did her undergraduate, and then Washington State University did a master's and Ph.D. in environmental science. And she is part of our Christina Lee Brown Envirome Institute here at University of Louisville, and she has worked her way up to an associate professor. And we are really thrilled that you're doing what you're doing because you can really, literally save the world. So thank you. I don't know if everybody knows this little dinging fact, but there are more people who have cell phones on this planet than have running water. And so having initiatives like the things that you're doing are so welcome. So thanks for all you do. And without further ado.
Well, hello and welcome. My name is Rochelle Holm, and I'm an environmental scientist with the Christina Lee Brown Envirome Institute. I hope to share with you today about wastewater surveillance or community health monitoring. I have a background in water, sanitation, and hygiene. I'm sorry you're eating lunch. We will talk a lot about poop today, and specifically in Malawi, where I've lived for more than a decade. I'll give you a brief background on wastewater-based epidemiology and environmental surveillance more broadly, and then jump into some of my past and ongoing research in Malawi. Thank you for attending today's Grand Rounds. So why are we talking about sewage surveillance? A bit of background. So wastewater covers the human-animal environment interface and is a key surveillance opportunity for public health. It has a proven track record in public health surveillance for environmental factors, infectious disease, illicit drug use, and more. But it's also an emerging area of environmental health expertise, including here at the University of Louisville, where we have more than 40 wastewater publications since the pandemic started using wastewater as a community health indicator. It also holds new promise fueled by the massive global investment in the science and technology during the pandemic, with investment across both the private sector to the Centers for Disease Control. So clinically, what is this? Urine, feces, plus small amounts of hair, mucus, skin, saliva, and blood are all combined with detergents, food waste, animal waste, industrial chemical waste, paper and plastic products, storm debris, water from rain, water from major appliances, showers. Combine all of that and you have a wastewater sample. So wastewater is a type of pooled sample gathered from the sanitary sewer system that includes biospecimens and environmental chemicals and materials from defined catchment areas associated with groups of people. But it does not meet the common rule definition of human subjects research governed by IRBs. There's no regulatory framework for this testing. So nearly 100 years ago, the success obtained by Wilson in 1928 in Belfast sewage by his method of selective culture marks a great advance in this branch of bacteriological investigation. Taking strategic samples of wastewater to trace carriers was published in 1929, and wastewater-based epidemiology was born. More in 1948 and 1952 further examined the tracing of the typhoid carrier from sewer manholes with multiple and systematic sampling. So we can look across chemical and biological indicators, enteroviruses, illicit drugs, alcohol consumption, tobacco use, dietary patterns, biological agents as weapons, and environmental toxins that cause cancer. So wastewater-based epidemiology looks at both fecal and urinary shedding. Many of the same methods already being analyzed for individual patient health with fecal and urine shedding can be additionally traced with wastewater-based epidemiology for a picture at a larger pooled sample of community health. During the pandemic, COVID-19 testing was difficult. Individual clinical testing of those presenting with symptoms, while effective, misses asymptomatic individuals who are actively shedding virus. Population screening is difficult and resource extensive. Repeated real-time population-specific results are difficult, and testing was not equally available for the most vulnerable populations in the pandemic. So I will present a few studies from other wastewater-based epidemiology groups. So using polio as just an example, where pipe sanitation systems, non-sewered sanitation systems, and environmental surveillance are well established. Polio provides a global precedent that urban and rural populations are included equitably, and especially the most vulnerable. These big polio surveillance studies show the value of this tool. But polio is a bit tricky for wastewater, as only the World Health Organization labs can perform analysis. You'll notice Malawi, it's up here. However, we have to send our samples out of the country to the World Health Organization approved lab in South Africa for those 10 sites. So samples just take a long time to get results back. Wastewater is also being used in many countries for the estimation and dose per capita of opiate consumption and to estimate the number of opiate users. Tempe, Arizona is innovative in providing illicit drug surveillance results on an online dashboard with wastewater results available. And nicotine human excretion studies have been developed that specifically correlate factors to back calculate nicotine intake by a population based on those metabolic residues measured in the raw wastewater. The Envirome Institute has also led research on exposure to volatile organic compounds by measuring urinary metabolites in wastewater. The UofL is leading innovative WBE approaches to potentially be able to assess community health exposures to indoor and outdoor pollutants. And during the pandemic, the UofL had an extensive SARS-CoV-2 testing program across the county. We looked at the time lag dependent analysis of the relationship between hospitalization rate and wastewater concentration in Jefferson County. Overall, our work suggests that under certain conditions, it is possible to use wastewater-based epidemiology to assess both immunity acquisition in the community due to natural recovery and vaccine, as well as the effect of variant emergence and associated immune evasion to the available vaccines. And extending this wastewater platform to monitor and survey areas with increased environmental health risks offers great opportunities. In the United States, colorectal cancer is the third most commonly diagnosed cancer and one of the 5 leading causes of cancer-related mortality. Despite a decline in CRC incidence rates among individuals aged 65 and older, mainly attributed to screening efforts, cases of early onset CRC patients, those younger than 50 years old, are rapidly increasing, with the projected incidence rate expected to double by 2030. Exposure to volatile organic compounds in occupational settings has been positively associated with CRC. However, many high-risk populations remain underserved by CRC screening due to age-related guidance or healthcare disparities. Yet, wastewater catches all ages. So a yearly environmental toxin sample to guide geographic boundaries for community-based interventions may be appropriate here. A complementary approach for CRC could be adopted to screen environmental toxins in wastewater, and when paired with ambient air monitoring, known registries, and biospecimens using geo-targeted resident areas, you can inform them of their heightened risk of developing CRC. So these populations are often experiencing higher exposure in environmental pollutants, but barriers to access and preventative and interventional healthcare services. So using wastewater with CRC could be part of the innovative work that you'll be seeing out of the Envirome soon. So we often think of 3 epidemiological frameworks for WBE. Many of us have thought a lot about community health data, not just where to sample, but also for health equity. For example, early in the pandemic in Louisville, we were over-selecting geographic areas for wastewater testing where clinical testing was not guaranteed. But this requires the ethics to make sure our sample sites for wastewater are not too small, and importantly, no personally identifiable information is included. Wastewater sampling allows data collection from defined catchment zones within communities, regardless of whether the residents have pursued screening or treatment in such areas. By monitoring the environment, as opposed to burdening the individual to overcome the structural barriers to screening, wastewater may be a novel solution to disparities with associated environmental injustices and healthcare access. So field methods are often grouped into three categories. A grab sample, which is a cup on a rope, and it only captures who has flushed a toilet most recently or in a point of time. Composite samples are a small robot with a tube that reaches down into the sewer. It collects a small volume of wastewater every 15 minutes, and then that is added together to a big jar, and then we can take a wastewater sample from that. Also, treatment plant samples. These are highly representative, typically capturing several thousand individuals, and we pull the sample before treatment. This is also the most common sample. So what about the public opinion to wastewater-based epidemiology? The American public holds opinions on a wide variety of health topics, ranging from smoking and vaccination issues, such as also healthcare reforms. The social license around this topic can be affected by spillover effects from politicalization and association with public health interventions, such as lockdowns, as well as trust in policies and responses by federal, state, and local public health agencies. For wastewater surveillance, the intersection of scientific ethics and the public's privacy rights is both important and complex because of the absence of national and international regulations. So our team at the UofL, we have led 3 papers on the public perception of wastewater surveillance programs in the United States. Currently, no existing precedent regarding health privacy in the context of wastewater surveillance is available. Participation is not entirely voluntary. Individuals within the community do not have the option to opt out of surveillance to preserve their privacy. Authorization comes from health officials and local governments with the broad authority to act and regulate to protect public health and welfare. And no established precedent for community health surveillance of this nature exists, which typically does not involve the regular gathering of public opinion or the provision of notice to gather input regarding sampling acceptance. In contrast, customers can opt in to other public health surveillance at restaurants and public swimming pools via a choice to utilize those businesses or not. In addition, health surveillance results at businesses are often prominently displayed in the form of grades or notices of violation. Alternatively, wastewater results are mostly published on public dashboards, which are difficult for the public to interpret. The aim of our team was to investigate public opinion to include what is the public knowledge, perceptions of targets to be monitored, and where surveillance should occur. What are the privacy concerns related to sewer surveillance as a public health surveillance tool? And what are the general privacy boundaries of respondents? Public attention to news peaks in relation to newly reported health threats and wanes when the media coverage fades. The United States public was seeing wastewater surveillance in the media regularly between 2021 and 2023, using search terms such as sewage, wastewater, COVID, monitoring, and surveillance. So we have conducted 3 public opinion surveys in the United States. The first survey was localized to Louisville, and we wanted to see the primary concerns that might come out or not. We conducted this study in August of 2021 as part of our ongoing COVID-19 community prevalence study in the localized areas of Louisville. The survey was comprised of 7 questions about wastewater awareness and privacy concerns and was sent to approximately 35,000 households randomly distributed within the county. A total of 980 adults were involved in the probability sample, and 1,700 adults additionally responded to the convenience sample. The samples were weighted to obtain estimates representative of all adults in the county. Public awareness of tracking SARS-CoV-2 in sewers was low, despite 9 local news articles in Louisville at that point, but opinions were strongly supporting the public disclosure of surveillance results. Responses showed that people more strongly supported measurements in the largest areas, greater than 50,000 households, typically representing levels found in large community wastewater treatment plants. Those with a history of COVID-19 infection were more likely to support highly localized surveillance, such as smaller sewer shed or neighborhood size. In effect, personal experience with COVID influenced the wastewater-based epidemiology public opinion on the size of sewer shed acceptability. We also saw opinions vary throughout the county, suggesting there is no generic opinion throughout Louisville. For example, in Area 1, which encompasses Western Louisville, it had the highest percentage of respondents that endorsed sampling areas greater than 50,000 households. Conversely, Area 4 had more variance across response options, indicating a wider range of views in that area of the county. In our second and third study, we used Qualtrics, a national research panel provider, to recruit participants to answer an online survey. Our second study was collected in the winter of 2022 across the US public. We had over 3,000 respondents, which answered questions about their knowledge, perceptions of what is to be monitored, and where surveillance should occur, as well as privacy concerns related to sewer surveillance as a public health tool. We also had a privacy attitude questionnaire to assess the general privacy boundaries of respondents. Public health agencies routinely monitor various activities that may pose health threats, including testing for air and water pollution, restaurant inspections for food safety, and inspecting hotels, motels, and public pools. We found lower awareness of sewer surveillance than to other forms of public health surveillance, such as restaurants and pool inspections. When we presented 10 applications in wastewater surveillance, alcohol, disease, gun residue, healthy eating, illicit drugs, lifestyle behavior, and mental illness, prescription medicals, terrorist threats, and toxins to participants, and we asked if they would support any of them. Participants were more likely to support wastewater surveillance for diseases, environmental toxins, and terrorist threats, such as anthrax. But we also found the most common category that respondents wanted to prohibit monitoring was at personal residences. Our concerns and privacy were in sewer shed size that may be acceptable and for what targets. We thought the opposing WBE public opinion was related to the invasion of privacy. And we thought that privacy may be an important functional use of our nationwide public opinion to gather more widely. For example, legislation opposing COVID-19 sewer monitoring includes North Dakota's House Bill 1348, which was aimed at prohibiting the testing of wastewater for genetic material or evidence of disease, and to provide a penalty. It did not pass in February of 2021. Other media reports focused on the privacy concerns of building level surveillance. The National Academies of Science report devotes an entire section to WBE privacy concerns and states that CDC should address privacy concerns. We used a validated privacy tool to test privacy concerns. The PAQ scores assess the willingness to disclose information that one might want to keep private. Low scores indicate willingness to disclose or a higher degree to remain private. The PAQ provides an indication of how people may feel about their personal privacy under 4 domains, beyond sewer monitoring and public health, including willingness to share personal information, exposure, willingness to be monitored, and interest in protection. The PAQ allowed us to triangulate with other survey questions, and we found that generally, violating liberties was not a dominant feature of WBE. Luckily, we did not find nationwide public sentiment that WBE was an invasion of privacy. Respondents were more concerned about sharing their personal information than the other 3 factors. Our third study was repeated in the winter of 2023, again across the United States using Qualtrics and the same survey tool as 2022. Considering the decrease in severity and mortality rate of COVID-19 and the increasing polarization of the field of public health from 2022 to 2023, changes in public opinion were expected regarding WBE. Consistently, though, our survey results again showed public approval for WBE for detecting pathogens, toxins, terrorist threats, and illegal activities, all of which could fall under the umbrella of defense against terrorism. However, wastewater-based epidemiology counterterrorism surveillance is rare. One explanation may be that coordination and oversight for the surveillance of this wide range of activities, which has public support, as seen from our survey, are likely to be dispersed and siloed. For example, public health agencies are likely to coordinate and oversee pandemic preparedness, environmental agencies would coordinate toxin data, and security and law enforcement agencies would oversee terrorist and illicit drug data. The coordination and scope of interagency wastewater surveillance in line with public opinion requires further consideration in future research. So some key insights and recommendations from our public opinion research to inform boundaries in the United States in the post-pandemic period Public education is needed. Currently, there is no anti-wastewater surveillance movement on targets or geographic scale. However, it is still important to take action to increase public awareness and buy-in. Potential activities include geo-targeted public education campaigns in areas where knowledge and awareness was low, including environmental education and health curricula. There's also a need for public education and advocacy with utility partners. Wastewater surveillance is supported at levels comparable with other public health surveillance activities. As with pool and restaurant inspections, health departments should establish policies and funding for wastewater surveillance. Support extends beyond global health threats and infectious disease. We should make room for other things to monitor with WBE. Toxins and terrorist threats offer opportunities to expand wastewater surveillance with high levels of public support, and this may open wastewater as an accepted method for other health threats. But support is conditional. Surveillance targets such as pathogens, toxins, biological and chemical terrorist threats, and illegal activities are generally considered acceptable. Sampling for lifestyle behaviors such as alcohol consumption and eating patterns is generally not accepted. There's an overall concern about keeping sample size large to maintain anonymous data. Sampling is most supported when the catchment size ensures fully anonymous households. We infer that the public does not want wastewater surveillance for individual human genetic surveillance. And lastly, the whole opportunity outside of infectious disease is unknown. Opening the discussion for a broader range of health targets to ask the public about their opinion in future surveys is needed. Health disparities among United States residents have been well documented. Many factors contribute to this, including poor social determinants of health metrics such as poverty, lack of education, and life expectancy. But rural populations have critical barriers to healthcare. There are fewer MDs in these areas, and rural populations are more likely to be served by critical access hospitals. This is important for public health surveillance as federal regulations limit the role of these hospitals in treating large outbreaks of diseases in rural areas, given the limited number of beds, hospital stay capacity, and reduced medical resources. Although these hospitals provide a critical lifeline for basic care for many rural residents, frontier residents must still travel long distances. In Kentucky, there are many rural areas where you're traveling over mountainous areas or areas that are prone to flooding. And innovative public health surveillance approaches are needed to maintain the health of residents and the capacity of healthcare facilities. Wastewater surveillance is a tool that can be used to provide more data in these rural and remote locations. Wastewater surveillance also has the potential to help mitigate the economic impact of disease outbreaks by preventing the spread and proactively addressing potential ones. This type of disease surveillance can overcome many barriers found in rural communities that contribute to health disparities. So how did I land on WBE in Malawi? When I joined UofL, I was looking to join my expertise in health monitoring of vulnerable populations with the UofL expertise in environmental health. But that being said, there are many challenges in establishing a lab in a resource-limited region to gain timelier and better quality epidemiological data for pandemic prevention. Disenfranchised and disadvantaged communities share many challenges across the globe. These communities are more likely to be poor and minority and disproportionately exposed to harmful environmental pollutants that requires access to equal healthcare. The environmental justice movement aims to improve and maintain a clean and healthful environment, ensuring healthy air, water, and soil. More than 8,000 miles away, two worlds apart, and yet many similarities. The environmental health agenda in low and middle income countries is often driven by donor demands or socially conscientious manufacturing and laboratory access more so than the community concerns and recommendations. This results in the polluted environment not being well defined for health. In Malawi, the EJ movement is not an issue because communities do not know what EJ is, not because there are no environmental pollutant problems. Learning from the COVID-19 response, we have an opportunity to innovatively advocate for environmental health justice for low income and communities of color. A bit of context. Malawi, located here on the map, Southeast Africa, about 2/3 of the population has access to basic drinking water. This is most commonly a simple farm-style hand pump where a woman is going to carry back the water to the household in a bucket on their head. Less than a quarter of households have safe sanitation at their home, and I will show you lots of pictures of pit latrines in the coming slides. And even in healthcare facilities, basic water and sanitation facilities are not guaranteed. A bit of a fun fact, the University of Louisville has sent surgical residents to Malawi for more than 10 years. The availability of and accessibility of water, sanitation, and hygiene services is key to preventing disease transmission. Here are the top causes of death in Malawi, including prominently diarrheal diseases. So water, sanitation, and hygiene interventions, they reduce the risk of diarrhea in children in low and middle income countries. Interventions supplying either water filtered at the point of use, higher water quality, and an improved source on premise, or basic sanitation services with a sewer connection have been associated with increased diarrheal reductions. Water, sanitation, and hygiene in low and middle income countries is highly tied to reduced diarrhea. The water, sanitation, and hygiene burden and link to diarrheal disease, though, is complex, and it's not just linked to households and healthcare facilities. Using the example of the fish value chain from one of my former students' research, fishers on Lake Malawi have no access to toilets and hand washing when they're on the boat. Limited access on the shore and in the transport route. And then in our local open air markets, if there are toilets and maybe water available, hand washing facilities with soap are rare. And while most households in the United States are on piped sewer systems, most households in Malawi are either pit latrines or septic tanks. On-site sanitation systems, a positive step toward improved household water, sanitation, and hygiene services, are used by 43% of the global population. So it's not just Malawi that's impacted here. So what is a pit latrine? I'm glad to see most people have finished their lunch. For context, this is a typical pit latrine in Malawi. For sampling, we can use household latrines or from community sites such as graveyards, markets, religious communities, and health clinics for community monitoring. Notice I did not say schools. Children do not poop at schools, and a lot of our indicators are fecally shed. So prior to the pandemic, I would ship samples of pit latrine sludge out of Malawi under a material transfer agreement. This was costly, and results took months to receive back. A household pit latrine is a bit like a time capsule of health of that household and their neighbors over the past 3 to 5 years. So research questions in this earlier work centered around pit latrines, layers, and pathogen detection. Essentially, can I scoop from the top? And yes, those are maggots. Or do I need to pump from the bottom, which is a lot more messy, requires a lot more time and PPE for a sample team. In this research, we actually found a variety of bacteria, protozoa, and viruses, and yet diversity was equal in the top, the middle, and the bottom. This matters for healthcare delivery in these areas of Malawi, where there's only one large government hospital in each region, but the drug supply is managed at a national level, and yet you can have regional differences in the pathogens that are there and circulating in different areas of the country. We also conducted genomic analysis on these samples. So both the PCR and genomic analysis indicated we can pull samples from the top of a pit latrine to get a good capture of community health. Here's a video at the Zaleka refugee camp where we are conducting pit latrine sampling for pathogens, just to give you an idea of the sampling method. Well said. The research partnerships are required to progress from individual clinical patient samples, which is happening at a limited scale in healthcare facilities, to these pooled community samples in terms of fecal sludge. The importance of research partnerships is not new, but possibly more complex in the Southern African context, which has 5 decades of human waste research. With no formal global networks, international nonprofit institutions and research such as mine can fill this role with UofL coordinating by bringing together academic research partners, public health officials, and the government for interdisciplinary and collaborative research and increased awareness and advocacy for health equity. Such partnerships can enable these settings to innovatively adapt academic or healthcare facility labs while maintaining high quality data and also promoting peer-reviewed literature originating from these resource-limited laboratory settings. So why should we establish a quality WBE or non-sewage sanitation epi lab? In the pandemic, the few global WBE adaptations for wastewater surveillance focused on field sampling design strategies rather than lab optimization or lab operations. Malawi has a decentralized healthcare system, and clinical results and testing would mostly only be available at these large regional or district hospitals. And Malawi had a devastating fuel shortage the last couple of years, which has impacted patients' access to get to those health facilities. There is a precedent to use sewage samples for baseline monitoring and catching outbreaks, but mostly only for polio. In February of 2022, Malawi declared a polio outbreak with 1 case in the capital. Currently, 10 sites are sent to South Africa for analysis, but that's not enough to cover the entire country. And we know that statistically, there are other cases that are asymptomatic in the population. In rural drinking water supply, there's a precedent for baseline water quality monitoring in low resource settings with more frequent testing using lower quality instruments. But beyond PCR testing, there are many pathogens that are able to be cultured, and culture methods have largely gone ignored in wastewater surveillance. There's a lot of literature on how to adapt clinical testing capacity in low resource settings. TB is one really good example that's well documented because it requires a BSL level 3. The UofL is trying to establish a replicatable model for wastewater epi labs in low resource settings for regular baseline monitoring, but also being focused on sharing our lessons learned. In 2022, the UofL partnered with the Malawi University of Science and Technology to set up a multi-pathogen baseline testing program. We are currently collecting samples weekly at about 10 sites. 7 of these are at a refugee camp in the central region, and 3 of the sites, 2 of which are healthcare facilities, are near the Malawi University of Science and Technology campus. We consulted with environmental health national stakeholders, including the Ministry of Health, UNICEF, and more. But as well, we want positive samples to catch a silent outbreak. There's not a good real-time death registry, so understanding real-time burden via both clinical cases and our wastewater samples is very important. We sample weekly and we culture immediately, and then run confirmational analysis on PCR paired with clinical results on a quarterly basis. We had a large cholera outbreak in 2022 and 2023 with 100 to 200 new cases daily. The results of the wastewater analysis paired very well with the national data that was available. We can get clinical results via a dashboard, which is that top image. It's sent out in a daily blast on WhatsApp groups. There is no online dashboard for the cholera data, and that's because internet access remains very limited in Malawi, and especially in the rural areas. One of the more valuable parts of our wastewater data was also watching the paired clinical data decreasing for the tail end of the cholera outbreak, analysis we're working on modeling in the next year. We do have a cholera vaccine that was distributed nationwide by the World Health Organization and the Ministry of Health. And just a few weeks ago, the current cholera outbreak was declared to have ended, but we still continue to monitor cholera on a weekly basis in our wastewater. One of the benefits of wastewater data is the relatively quick turnaround time. Taking the example of the recent cholera outbreak, which started in March of 2022, the OCV was not available until May of 2022, and only in select areas for humanitarian response before being available throughout the country later. Whereas for COVID-19 in 2020, we had very few national cases, and this was also reflected in our wastewater. COVID-19 vaccines are available in Malawi for adults, but not for children. Salmonella typhi is a bit different than cholera or COVID, as a vaccine is not available in Malawi, and we have only had 2 detections in wastewater. So this is a case where healthcare delivery and response is not as clear of a use with our wastewater data when it's paired, when there's not a vaccine available. And here, bacterial accounts range from 10 to the 6th for Vibrio and up to 10 to the 7th for Salmonella typhi. So the PCR isolates showed the availability of our culture methods worked really well for Vibrio, less well for Salmonella typhi. And although the culture-based methods are labor-intensive and have some limitations, we suggest in a low-resource setting, they're a very good first step on the ladder and applicable to many other low and middle-income countries. I do want to highlight, it took us 12 weeks to set up this culture and PCR lab. Even at MUST, we only have access to a BSL level 2, which limits the pathogens that the UofL can add to our research. Primers and probes were shipped from South Africa. They got stuck at the airport for 38 days in an air-conditioned room as we were on pins and needles knowing our primers and probes were so close, and government protocol meant that we could not get them out of government customs clearance any faster. So Malawi hosts more than 50,000 refugees and asylum seekers. With a monthly average of 300 new arrivals, 48% of these new arrivals are children. The camp was initially established to host between 10,000 and 12,000 people, but now hosts over 52,000 individuals. Currently, I'm an advisor to the United Nations to examine the potential application of WBE for infectious disease in these displacement camps. So worldwide, refugees and asylum seekers more so are hosted in low and middle income countries. You just don't hear about it. Displaced people living in camps may be particularly susceptible to infectious disease due to a variety of factors like overcrowding and inadequate environmental health conditions, which could be additionally monitored with wastewater and environmental surveillance. The potential for WBE in these displacement camps remains largely unexplored. So the existing clinical surveillance efforts in these displacement camps is very limited, and the care-seeking behaviors of the population is also complex. Forcibly displaced people often have language and cultural differences, which could reduce their likelihood to seek healthcare. So the camp is broken into several zones, and due to the recent polio case, we are very concerned about polio being at the camp. However, we can't get a positive control for polio, so we had to drop that important pathogen from our analysis. Different from the other sites that we are sampling throughout Malawi, the Ministry of Health has come along so that we have confirmation using Vitech to support our culture work. But given the sensitivity of sampling wastewater, considerable attention has been given to community engagement. We work with the head of institutions, the local radio station, and grassroots health surveillance assistants to raise awareness about the project and seeking healthcare when symptoms appear. Data is reviewed every Friday with stakeholders from the Ministry of Health, UNICEF, the World Health Organization, and I'm on those calls every Friday with these key stakeholders. In the event of possible results, these stakeholders would work together to target necessary interventions like vaccine, hygiene, promotion, and bucket chlorination. So some advice in Malawi and these challenges: focusing pathogens endemic to the particular region and targeting those that are accessible based on the available infrastructure. Here, we've used existing laboratory expertise and validated methods of culture. Human resources, they matter a lot. We have started with a workforce trained in medical microbiology and provided hands-on training for the WBE work. The laboratory has to have some SOPs before you come in to set up an operation like this. Site coverage, initial sites should be locations known to test most likely positive so that you can catch that silent outbreak early. And adapting equipment where needed, that's one of our key things. We just make and reuse what we have available as much as possible, but also having alternative analysis methods ready to go when the supply chain takes 12 weeks on something. Having external funding for proof of concept research, long-term lab operation and maintenance has to include other things in this work, such as internet and backup power, and guidance on wastewater or non-sewerage sanitation laboratory surveillance operations may be challenging to obtain or do not exist in many low and middle income countries. there's a complementary role of wastewater data with regard to clinical data, but it should always be used together in a defined system before starting to clarify the goals and complementary partnership between clinical and wastewater. And ethical considerations include both academic approval and approvals from the sample collection sites. One of the private hospitals we were originally looking at took a long time to build trust before we could go get those samples. They thought we were coming in for quality assurance from the Ministry of Health. And once we overcame that trust issue, we were able to go in and sample that site effectively. So the widespread interest in WBE has emerged during the pandemic, and it's also presented an opportunity to increase investment in surveillance globally. The potential benefits of this line of research are vast, but capitalizing on these benefits requires thoughtful partnerships and exchange to promote rooted collaboration that help mitigate global disease burdens. And there's a lot of thought leadership happening in this field. So some of my current research in the last few minutes. Funded by the NSF, I hosted nine students across the University of Louisville and North Carolina State University. With me this summer, they just left in mid-July. We conducted a Malawi-based wastewater-based epidemiology public opinion survey, looking at those culturally relevant factors that may be different. This was outstanding research done by a UofL honors student. And as we looked to use this research at the UofL as a model across low and middle income countries, it might be difficult to know where to target next. So given the limited global health funding, this model predicts and provides an automatic screening process for considering where investment in WBE should be next. This is a group of medical students from the Distinction in Global Health track that we've recently conducted this analysis with, considering conflict, enteric disease burden, water sanitation and hygiene infrastructure, and health policy to guide wastewater and environmental surveillance in low and middle income countries. So in total, there are 7 clusters here. And the country clustering framework provides a balance by offering several policy and investment profiles without overwhelming complexity. With this framework, the targeted deployment of WBE can provide data to determine targeted prevention and treatment that can reduce low and middle income country enteric disease morbidity and mortality. The innovative model here is really suggesting where WBE should be avoided, and that might be due to conflict. You'll see at the top. And a couple of these also is because of internal capacity. Those are areas WBE may not work. In low and middle income countries, it is ultimately the Ministry of Health that will need to lead WBE through a global scientific collaboration. And as we look at innovative quality assurance, our laboratory has open windows. There's no air conditioning. A limited detection study is not possible because that would be so many supplies to use, not on samples. Our PCR analysis is carried out once, not in duplicate or triplicate, and our unused PCR wells are covered very carefully. After the plate is run, they are uncovered and used on the next run. So by partnering with an outside lab that can run a full LOD study outside of Malawi, we are able to get our LOD work and do an LOD light in Malawi for validation. But sanitation is about people. We also have cases in Malawi where pit latrines are emptied when full, and this waste is indiscriminately disposed with no treatment to the land. I have found this illegal activity in action, and also the harvesting by poor farmers who use this human waste as fertilizer. And so this is one of our respondents saying, I was only doing it because of poverty, you see. There was a lack of fertilizer available. So when handling, I'd be using bare hands as it was dry. But if I had chemical fertilizer, I wouldn't have done it. And so sometimes when we talk about wastewater and environmental surveillance, we have to remember that the most vulnerable population may have a different risk than our sampling design, and it may not be covered. I do want to acknowledge who is left behind when sampling in Malawi, because this is better community health surveillance, but it's still not full coverage. There are boundaries, and this applies to both Malawi and other low and middle income countries. If I can't send a technician in to sample the pit latrine safely, such as if it may collapse, I won't do it. But sandy soils where pit latrines collapse regularly, such as along the shores of Lake Malawi, which is 350 miles long, are very difficult to sample. Also, people with disabilities are disproportionately impacted by lack of access to safe and usable toiling facilities. So if you are here today at Ground Rounds as an educator, where does WBE fall in medical student education? Currently, medical students learn about urine and stool samples as one of the many diagnostic tools that can be used to understand a single patient's infectious or gastrointestinal pathology, or, for example, pregnancy diagnosis. If discussed at all, WBE may only be covered in special discussion groups on public or global health as an interesting subject unrelated to patient care. During the COVID-19 pandemic, Public Health Department Chief Medical Officer leadership began overseeing WBE data use and interpretation to guide health risk mitigation and intervention. So professionals in the medical field, including not only doctors, but nurses, are lacking exposure to WBE and its possibilities, even in their undergraduate studies. WBE offers an opportunity to teach medical students to pre-test probability. Knowing the community level of a pathogen should result in a higher awareness of what may be most likely in a patient with corresponding symptoms, and knowing that a rare pathogen has been detected locally could result in faster recognition of concurrent cases. WBE offers physicians an opportunity to better care for patients with diseases seen at regular clinics, customize and inform treatment, and accept positive results as true positives, backed by the contextual information provided by WBE. For you in the audience today, I would advocate, if you're a medical educator, to include WBE in your medical student education. So where does this field fall into for Malawi higher education? In Malawi, less than 0.5% of the population has attended university. So public higher education institutions are key capacity building organizations in low and middle income countries. And at the UofL, partnering with the Malawi University of Science and Technologies, we are building a sustainable capacity. We have also been working on improving health-related employment opportunities in Malawi. Over the past 10 years, I've been holding an annual STEM camp for local girls aged 5 to 18, and this year we held it for 250 girls, elementary age girls, and the theme was WBE and healthcare workforce gaps. Lastly, I want to acknowledge the amazing team behind all of our WBE work, and I'm happy to answer any questions. Thank you.
About acceptability and that sort of thing, but we're doing here somehow as we are today.
So I would say with the Envirome Institute, we are monitoring a variety of targets for Jefferson County VOC metabolite. We are doing SARS-CoV-2, flu A, flu B, and RSV on a weekly basis. And we're looking to add other environmental toxins to our portfolio with grant proposals in the coming years. I would say they're different. So there's a lot of similarities in healthcare access disparities between vulnerable populations across the world. But in Malawi, we have even less patient testing. So wastewater provides an even bigger step up for response of public health agencies. When you know that your population cannot get into the healthcare facility because of fuel or money or lack of education to know to come in, you can't catch a silent outbreak. We are doing a lot of work here in Jefferson County. The team with Dr. Botman. Thank you so much.
So during COVID, this not started here. Incidents of disease was so we did in-person testing and big-pharma testing across the county in a randomized fashion based on the needs. And so we did it every other month, yes. And then we did the wastewater testing every week at 30 sites across this. We did all the schools. In fact, we did all the presidents in the state of Kentucky. And we started that for 3 years. Now we're doing it bi-weekly basis. And not only do we look at SARS-CoV-2, but we do complete genome sequencing, able to identify new pathogens. And so that's funded by the state, and we hope to continue to do that in the future of health.
So that's a 3-year project. for Jefferson County. So that's great for Jefferson County residents as well.
You mentioned that they get
We would be able to as part of our genomic surveillance. But as well, measles in under-vaccinated populations. That's a problem in both Malawi and America. Yes, please.
And then they have I believe that some of the toxins that are
Yes, very much in Malawi, especially because our most common household sanitation facility is a pit in the ground, and we're drinking from rural water supply. So a simple farm style hand pump would be an improved drinking water supply. There are many households, especially in rural poor areas, that are still doing scoop holes from surface water, and those populations probably don't even have a toilet. One of my early projects was working early in my career, working with people with disabilities and trying to make their toileting facilities more accessible to them. So we try to keep toilets away from the household, except, you need a little bit of buffer. If you're a person with disabilities, moving that household toilet closer is very justifiable. But yes, in Malawi, the contamination of groundwater from pit latrines is very common. Similar in India and Malawi, yes.
so ethically, I see this and I agree with it. But I wonder, there's not an infinite amount of money in the world. And so I wonder, what is the actual population value add? And does it fit with the World Health Organization guidelines of things that we should do that are value added, like $50,000 for every quality just life or things like that, in relation to other population health interventions? Because the reason that came to my head is that I love all the data, but it shows that the population prevalence of these diseases in Malawi are very, very low. I mean, most of the time you're not picking up any disease. And so what's the value?
So cholera cases, we had several hundred a day. If we can decrease that number, I'll use the example of the refugee camp. There's a history of refugees and displaced people to not seek healthcare, is if they have a tick on their portfolio for trying to get their paperwork, it could jeopardize the timeline. So because of that barrier to seek healthcare, wastewater is providing a sample of everybody equitably so that decision makers can come in with suitable interventions. The worst case would be coming in with a cholera intervention when there is no cholera. Waiting for the area to have cholera and being ready would be a much better use of resources. So the refugee camp, we work very closely with the World Health Organization, and I respect the humanitarian part, and they want the vaccine preventable pathogens analyzed at the camp. That's your example. Where can I respond? Where can I mobilize? A cholera vaccine, although it is available, it's very difficult to mobilize because it comes from WHO. So it still takes months to get it. The polio case also kicked off several vaccine campaigns. Again, it takes months. So if we can provide earlier data to the Ministry of Health, they probably won't make decisions on our data, but they could ramp up clinical testing. You're always triangulating all of this data.
So follow-up question. So I have a So I have a friend who wrote a book about economics of vaccine and stuff like that. And so his argument was that in the next 5 to 10 years, issue in that a lot of ministries of health have been reporting slowly increasing. They want money to keep money flowing in and show that they're right. But at some point you have to answer because you get 99% coverage view. But that's not true. That it's really 50% of them because you haven't gotten it out throughout 3 months. So have you ever run into a situation where you have to be because wastewater can answer that question?
Absolutely.
So, or even if you haven't used it, how are you going to interact with the ministry at that point?
I love this question.
Yeah.
So it's a decentralized healthcare system. The government hospitals in the large regions, they're doing the surgical cases, but in Every cluster of 3 villages has a rural health surveillance assistant. That is somebody with a secondary school education that is giving under 5 vaccines and family planning services. My observation is wide vaccine access and acceptance. There's no anti-vaccine sentiment in Malawi. I've never seen it. Now, there have been shortages at times, but we don't see that anti-vaccine. So when Malawi posts 99%, my observation, and I've worked extensively with these grassroots, if I am seeing it in the village, I feel that their data is accurate, at least in the lab. So I would like to read the book. It sounds great, though.
First of all, thank you for doing this. I mean, this is a really underserved area, and just to be able to be there and all the stuff, things that you do there with the girls' camp and the science camp, and trying to keep that on going on. It's really commendable. Thank you for doing that. But follow up just about the value of this. Do you know, or can you cite an example where wastewater surveillance was able to drive public intervention of public health policy?
Yes.
Some sort of a change.
Yes. So we had probably about 1.5 years ago, one of our wastewater samples detected cholera. That healthcare facility could not test for cholera at their clinic. They reported diarrheal diseases. So when we detected cholera, we were able to alert the health clinic to say, if you have explosive diarrhea, not just normal diarrhea, please know that your samples are showing cholera and you need to refer them as soon as possible to the larger government clinic. So that was a very clear example where we were able to use our data for not only early warning, but advocacy for the clinic to be given more resources for those referrals.
I get the important down from Colorado over.
Oh, I got my vaccine when it was available publicly. I got it too. Thank you very much.